Hi, my name is Dr. Daniel Reeders. This may be a long talk. Um, this is more of an introduction talk to um, reorient your thinking in terms of what everybody is talking about. As you go out to restaurants, if you go to restaurants or wherever people meet and greet, you often people talk about their cholesterol and whether they're going to go on a statin or not, and their cardiologist. And it's fairly common things to hear people talk about that, wonder about, talk with their friends about. It's a thing in our society. And this lecture is meant to change a perspective about it. So there will be other YouTubes that I'll be putting out that will talk directly about different treatments and different topics. Um, and so this is just a orientation. So nothing's being sold here, and just to reorient you to what's important. So let me go back and tell you about who I am a little bit. I've been a cardiologist for, let's say, 4 decades. And when I was in medical school in the late 1970s, I graduated in 1980. My clinical preceptor mentor was David Blankenhorn, who was the chief of cardiology at the University of Southern California Keck School of Medicine in Los Angeles. And he had published an article in 1978 where he showed that high-risk patients, such as bypass heart attack patients, um, he could reverse the plaque inside of femoral arteries. So one concept is all arteries are pretty much the same, of similar caliber. And so the femoral arteries things, it's an easier area to access, less invasive. And um, what he showed is that you could make the clogged arteries in these femoral arteries reverse by things such as stop smoking, eating a good diet. He put everybody on cholestyramine is tolerated, which binds cholesterol and toxins and goes out into the feces, and a niacin, which is a vitamin which can make you flush. And he showed that he could make these arteries blockages, plaquing inside the vessels get smaller in general. So this has been proven. So this is like almost 5 decades ago where there was scientific proof about this. Even developed a new way to quantify these blockages with the Jet Propulsion Laboratory in Los Angeles, the rocket scientists that put people on the moon and so forth and so on. So then, after my internship and residency I did there, I went across town to UCLA, and specifically the VA, Wadsworth West LA VA. And there, my mentors, particularly Dr. Brahma Singh, told everybody, well, this elevated cholesterol is just an unproven hypothesis. So during my 2 cardiology fellowships, I did not treat one patient for high cholesterol as a cardiologist in training. So I've had quite a bit of time, 4 decades as a cardiologist, to think about these things, including all the new research and so forth and so on. So that's my perspective of how I look at things right from the very beginning. So what I intend to teach, so some of these slides were made for physicians, it's okay. Um, but what I intend to teach here is that heart attacks, including also strokes, which are also vascular disease, um, what I want you to learn about is the basics about these things and what's important. Um, so there's a lot of concepts I'm going to give you that have been known for many decades. And so none of this needs to be controversial. It's all well-known information. And that the presence of vascular disease, which we're talking about heart or brain disease, we're talking about the arteries that feed these things with oxygen and glucose and other goodies. If they never get damaged, then often you wouldn't develop a stroke or heart attack. So the place where we need to do so-called prevention is looking at vascular biology, the arteries that carry red blood, and these things get hardening over decades. And so for decades, it's silent, and then often, if you get a symptom, it can be death, heart attack, stroke, awful things like that. So hopefully, and we know as a scientific fact that if you intervene earlier, that you can prevent these things, especially with the potent information that we can make these atherosclerotic plaque inside coronary arteries and other vessels get smaller, regress. So the real, so there's two types of plaque. There's the soft plaque and the hard plaque. And the hard plaques, the deed's already been done. They're calcified. What does calcium mean? It's like they're turning into bones. That doesn't seem like a good thing for vessels. So we want to treat earlier and prevent the soft plaque from forming and from growing. And we want them to go get smaller. And there's a specific type of soft plaque called vulnerable plaque or necrotic plaque. And we can measure these things, and that is where this lecture is going to focus on necrotic plaque and soft plaque. The necrotic plaque is the 911, the emergency. And just to also go on, the main drivers of events, they're called cardiovascular, major adverse cardiovascular events, and I'd add in there cerebrovascular. The main drivers are metabolic disorders and inflammation, and that we have a systemic failure that we're hyper focused on calculate LDL-C and statin drugs. And toward the end of the talk, I'm going to talk about how this has failed policy. So don't give up on me too early. You can listen to part of this and re-listen and then just make it all the way through. I suspect this will be about an hour-long talk. So let's keep going. So what is practiced and is the old theory that was debunked about 5 decades ago scientifically, that we have healthy arteries that turn into soft plaque, that turn into hard plaque, and it's a one-way street. That's what everybody practices, and that's in what I see in just about every hospital and healthcare system and policies and bean counters and in our culture. Culture is very hard to change. So what was proven a long time ago was that we have so-called healthy arteries that become soft plaque. This can be bidirectional either way, and the soft plaque can form into a type of soft plaque called necrotic plaque, and then this is bidirectional, and then it can also turn into hard plaque, which is calcified plaque. So a lot of the cardiologists know this and they say, well, I'll put you on a statin drug and this will make this vulnerable necrotic plaque a stable hard plaque, and that is true. And it doesn't address this other part of the equation. So one concept I'd like to get going back when animals appeared on this planet we call Earth, um, God, she invented cholesterol. And we believe the main purpose of cholesterol back then was to soften and make the cells more pliable, functional, because cholesterol would sit inside the membranes of the cells, including the organelles inside, like the mitochondria, which make ATP and do other things and make them function better. And so the primary evolutionary reason we have cholesterol is to make more complex functional, highly functional cells. And so I'd never go against Mother Nature. Also, cholesterol has a lot of other uses, such as they're first responders. HDL and LDL cholesterol, the so-called good and bad cholesterol, are first responders. When we get eaten or bit by a saber-toothed tiger, it will go right there to the injury to save our lives. So this has become maladaptive vascular biology in a modern society, which we'll talk about. And we need it for bile acids and vitamins and all of our hormones like cortisol, certain hormones like cortisol, aldosterone, which is a blood pressure fluid thing, uh, pregnenolone, and progesterone, the androgens, which are the male hormones, and the female hormones that come from the male hormones, the estrogens. So it's a precursor, it's substrate, and more. So let me tell you the story of the king that lost his keys to the palace. The king left the palace, went out into the kingdom, visited the kingdom, came back at night, and his people came and saw him under a lamppost on his hands and knees looking for his keys that he lost for the palace. And his people said, "What are you doing on your hands and knees underneath the lamppost?" And he said, "Well, I lost my keys." And the villagers wanted to help out, so they asked him, "Where was the last time you saw them?" And he said, "Well, over there in the darkness." And then they said, "Well, why aren't you looking there?" And the king said, "Well, that's not where the light is." So let's enlighten. So cardiac and cerebral vascular and other arterial events are silent for decades until there is a plaque rupture and thrombosis. Then it can be a catastrophe, such I spoke about death, sudden death, strokes, heart attacks. And so if we're only enamored by where the light is, the moon, which I advise everybody to go if that's what they resonate with, we're going to miss where the action is. And this planet is being harmed by not looking in the right place where the keys are. So let's find the keys. So cardiologists are generally overworked. They wake up in the middle of the night, bless their heart, they run in and put stents and heart attacks and do the good work and are exhausted and keeping people alive from these catastrophes. So they put stents in and send people for surgeries, prescribe statins, and the rest of the work is expected to be done by everybody else. One of the failures is they don't tell anybody what everything else is, as we're hyper focused on cholesterol calculated and statin drugs. This is so I had a recent experience less than a month ago where I was in the hospital. We got a patient catheterized. They had a coronary angiogram. They needed bypass surgery. And the hospitalist says, "Well, in 3, 4 days, this patient's going to have bypass surgery. What do I need to do?" So then I told this hospital doctor, "Well, let's stop the aspirin and Plavix, which are antiplatelet drugs, and talk to the surgeon, see what they want. But please don't stop the heparin because this patient had an aborted heart attack. And then you need to focus on things such as inflammation and metabolism. They say, doctor, cardiologist, this is not important to me. I need to just get this patient to the surgery, and this is not important. Bless their heart. And so I couldn't convince them otherwise. The hospitalists are also overworked and they have too much to do, and they just need to know what to do for the next day. And I have low thinking that when the patient has surgery and gets discharged, that the inflammation or metabolic disorders and other things are going to be addressed. So this was a failed opportunity and a failed medical um, policy and practice. And consider that people that have their inflammation and metabolic disorders and other issues remedied will do better even with their bypass surgery, no matter what. So that work needs to be done. So what is a vulnerable and soft plaque? So bear with me, I'm not trying to make you into a cardiologist, but you see this artery, and then it's this plaque in here, this cholesterol and stuff filled with necrotic tissue, which is dead tissue, inflammation, other processes. And this doesn't occlude or obstruct blood flow, but what happens is during a patient's life, these things crack open and seal, crack open and seal. And sometimes the crack is so bad that a blood clot forms and it occludes the whole vessel. There's no blood flow. That's what causes the strokes and heart attacks. So this is the first 911 where we want to look at, and these are silent practices, and but there are ways that we can evaluate them ahead of time, and we don't need to wait for the catastrophe. Often, patients come back to nephrologist. Don't send the patient back to me until they need dialysis, or the cardiologists don't really, they'll see him in clinic and do their thing, which is mainly a lipid cholesterol centric. And don't look at the other things. It's just not part of the practice. So imagine if you can prevent these catastrophes, people would be still working and still be fathers, mothers, sisters, brothers, parents, and people that were productive humans to our society. And that would decrease global dollars and global healthcare dollars. That's my opinion. Other people can disagree. So some of the drivers include inflammation, metabolism, metabolic dysfunction, regulation, and thrombosis, which we're going to talk about. And so the bottom line is that these things are silent for decades until they become catastrophes, usually, not always. It's the number one cause of death in the United States in modern societies. Now, some places it's not the number one cause, like in parts of Japan and some of the blue zones, maybe Amazon basin, heart attacks are rare. Why is that? Well, in Japan, there's a theory that they eat a lot of fish. So that's one theory. Could be something else. And they come to the US and they develop the same amount of heart disease. So that's part of the hypothesis. So it's silent. So we need to look for silent signals. That's what this lecture is about. For the number one cause of death and destruction. So no matter what you're being treated for, whoever's treating you, this always has to be remembered that this is so important that we need to figure this all out. So I'd like to do a case study of an apparently 71-year-old healthy male, asymptomatic. His father had his first heart attack at age 54, inferior wall, which means the bottom wall of the heart, a full heart attack. And this patient's active, they're overweight, not obese, and they have belly fat. Belly fat is extremely worrisome. It's highly metabolic and inflammatory and is not so good. He had an elevated LDL-C his entire life, and his lipoprotein A has been significantly elevated his whole life. So he'd been on lots of supplements and lifestyle and been on and off statins for decades. He's had injuries and health challenges, chronic stress, which continues, and he's no symptoms. Then again, he's a male. Um, Please note that also males drop out earlier than females because of heart attacks and strokes. Drop out, that means they've died or become disabled or whatever. So for some reason, a CT angio of the coronaries with AI reading was performed. There's many different technologies. This is just one of them to demonstrate. So the first part of this test was a calcium score, which showed elevated calcium score over 234 angstroms, anything over 100. It's an algorithm developed by Matthew Budoff. He was at UCLA Harbor when I was at UCLA, and the the way the algorithm goes, if you have a certain calcium score, there's a correlation and you get put on a statin, and it's severe, then you get tested for seeing if you need bypass or stent. So it's a signal to put on statins and a signal perhaps to do further testing. So one of the things is a positive calcium score, which this isn't severely elevated, pretty much only represents hard plaque. So this is already soft plaque turned to hard calf plaques. And um, so, and I even question, what do we care about targeting the hard plaque if the action is at the soft plaque, in particular this vulnerable plaque, this necrotic plaque? So a positive score just triggers these treatments. Every patient that walks into my office, adult patients, I assume have atherosclerotic plaque. That's my number one assumption. I know it for sure. It's just how much soft plaque and necrotic plaque are the important things I'm trying to convince you of. So, by the way, a calcium score often isn't approved by insurance, so you have to fork out some dollars. There, it's not a lot. You get some X-ray exposure and you get a number. So there it is, where CT angios, which were done, are generally, if they're coded correctly, get covered by all insurance companies, which may require prior authorization and a positive result there. So the heart has three arteries. There's one on the right coronary. There's one at the left main that bifurcates, turns into two arteries. This patient also had a little branch called a ramus medianus in the middle. And this scan showed that there was ischemia. That means severe blockage of significant blood limiting flow in the proximal right, the beginning of the right. It was measured at 76% and deemed ischemic. And this vessel in the back of the heart, this is like circles around the circumflex to the back of the heart. This was 100% included. And then there was a large plaque involving the left main artery going into the back artery and the front artery, a huge non-obstructive plaque that had some hard plaque and soft plaque components and also had necrotic vulnerable plaque. So if the heart has three heart vessels and two of them are ischemic of the three, and one is of those is completely occluded, and there's large non-obstructive plaque in the third, which is the critical artery, that's like scary to me. That's like a 911 for my patient. So they analyzed by the AI the plaque types and found out that there was hard plaque, which was 115, and soft plaque, which was greater. So there's opportunity there. And this would be deemed moderate plaque. And there was less than 4% um, necrotic, low non-calcium, low density plaque. So under 4 isn't normal. It's just not, that's the wrong word. It's not like high risk patient. So in my patients, I want them to not, if this patient had a 1.3, I'd like to get that to 0 because you really don't know. And I know there's studies in correlation, but my target for this patient would be to get this to 0 and then start regressing this soft plaque. And the pathophysiology is similar and the markers are similar, as you'll see. So what is a plaque? So this was the angiogram part of the right coronary right here, RCA, and the cursor's right there. But if you look at the outside of the vessel in different views, it looks like there's some barnacles on the outside of the vessel, which we'll look at the next screen. And there's no occlusion here like there is down there. So if we look at that, you see the vessel and it's all filled in. So there's 0% occlusion of this vessel at this point. There's normal blood flow. And this was the right coronary. So if we look again and look a little closer at these barnacles, they're not really barnacles on the outside of the vessel, they're actually inside the vessel wall. This is inside the vessel wall. This is inside the artery. And so this is not on the outside. It matters. It's in the vessel wall, the wall of the vessel. No, not so good. And so that's scary looking, and you need to see this, in my opinion, because it will just give you more, seeing is believing. And so if you move the cursor down into the middle of this vessel there, where the beginning of the vessel there at a blow up, it looks, the net lumen looks pretty narrow there. So if you want to do a cross section of that, if you look at the vessel, inside the vessel wall, there's all this junk, cholesterol and necrotic tissue in there. And then the blood flow compared to that big open normal blood flow is limited and determined ischemic by the study. So it looks like blood is barely squeezing through. This is an asymptomatic, apparently asymptomatic patient. That's so interesting. And then if you're not an angiographer or a cardiologist, but this vessel looks like it's called remodeled, and it was actually measured as remodeled. What does that mean? So people that read these studies would say this vessel has already been 100% occluded and on its own opened itself, not opened itself, but the physiology and the biology opened this vessel up. So this vessel was already occluded. So this patient already had a history of two completely occluded vessels of their heart and who's asymptomatic and has a large plaque in the other arteries. Scary stuff. So just for fun, let's look at the other artery, the left main artery where they identified the plaque. So you notice all of these things, vessels there. And if you look where it bifurcates, where it turns into another branch comes off this main artery, there's a big old plaque inside the artery wall. Just imagine how this can push, can crack, can distort the vessel. So this is really not a happy situation. This is serious. This looks like it's the size of the lumen already. So this, in my way of thinking, is not something that just you just say it's non-occlusive disease and don't worry about it. So what are your next steps? What are my next steps? Well, I referred the patient to Stanford. Patient was started on Plavix, which is a antiplatelet, so and aspirin, which are both blood thinners, so to speak, Repatha, because we know from a year previously the cholesterol, LDL cholesterol was not at goal. Repatha is what in the group called PCSK9 inhibitors. The the they were also on rosuvastatin, also known as Crestor, and 20 milligrams is a good dose of Crestor, and it wasn't getting us to the goal of the cholesterol. Repatha also can decrease lipoprotein LP little a, so that's added value. And retatrutide, which is a new GLP-1 agonist that blocks three pathways instead of Ozempic, one pathway, and Mounjaro Zepbound, two pathways. And other things that the patient was also on Zetia, which helps you poop out the cholesterol and other things. And so it was recommended they get newer labs done in a coronary angiogram with likely angioplasty, a stent put in that proximal right coronary. Scary stuff. So the clinic doctor in Stanford referred this patient for a cath, and they had a cath, coronary angiogram. And the EKG done before showed that the patient had a new inferior wall, bottom of the heart attack since November 2023. This is in 2025, this patient. And like father, like son, he had an inferior wall heart attack, albeit silent. The echocardiogram, which is ultrasound of the heart, was normal. So they didn't show the inferior wall infarct, but it may have missed something. Then again, it was done at a reputable institution, Stanford. So it's good news. And then the cardiac cath was done, and it showed the right coronary was only 60% clogged. So they stuck a a wire down there, and it showed no ischemia, unlike the CT angio. So there's no indication to put a stent, although CTAs showed ischemia in two vessels. The left circumflex, the one that went around the back of the heart, was open. There was no disease, no clogged, although it was occluded in the distal part in the bottom this on the part on CT angio, and the left main was normal. And the ETA showed extensive non-obstructive plaque in the left main into the LAD and circumflex, front artery, back artery. And they showed that the front artery had a non-obstructive 20% blockage. So this patient needed medical therapy and was sent to the recovery area. And then the first question is consider that both the angiogram and the and the CTA were accurate because they measure different things. The CT angio, and so the information was complementary. So the cath wouldn't show the soft and hard plaque. It would only show the stenosis, so to speak, and that it's been almost a month and intense therapy had been done, including aspirin and Plavix and Repatha. And so there was intensive therapy already done. And so this patient has extensive soft plaque, which has been made visible by that test, which even the traditional cardiologist at Stanford would never know unless they looked at the result and read the study. There are other technologies. So the question is, what do we do next? And so back in the cath recovery area, the clinic cardiologist was kind soul and visited this patient. And he said, well, we need some new lab work. And and so the patient asked, well, and so they're going to get a cholesterol level. So the patient asks, since HSCRP, which is an inflammatory marker, is more predictive than LDL-C, can we get that? And can we also get an ApoB and maybe even a small dense LDL, since they're more predictive than just the LDL-C calculated? C stands for calculated, not measured. And the cardiologist said, true, but I don't know what to do with an elevated CRP. Maybe take a baby aspirin. So this patient already been put on aspirin and Plavix by me, and um, and was asked, and then asked, don't you think Plavix would be preferred in this situation over aspirin? And they said, yes. So the cardiologist went ahead and ordered the lab work after the request was placed, and patient went home. A few hours later, they got the results. Their total cholesterol was really low at 79. The triglycerides, the fat was 18, very low. HDL, which is so-called good cholesterol, was in the normal range. The calculated LDL-C was 15, which is really, really low. And they consider the goal less than 30 in a patient. So this is at goal. And this was on Crestor and Zetia, retatrutide, and Repatha, and other things. So I said Crestor 20 is pretty much of an optimum dose, not much benefit going higher than that. It's also known as rosuvastatin. By the way, this precursor, which is still around a lot, is Lipitor. So most patients end up on Lipitor or Crestor. Lipitor was the first 1 billion with a B drug, I believe. What would we do next? So I'd like to just change the flow, and can we do better? Yes, we can. So bring up some things. So the cardiologists look at things as risk assessment versus management metrics. So for instance, if you have a cholesterol and you lower it like an LDL-C, that's a metric, whereas a risk factor may be something that they don't think can change like a lipoprotein A. And that's just a marker. And so, yes, even chronic kidney disease is reversible. So this distinction can be true in some parts, but looking at risk versus management, I think most things can be managed and improved. So yes, we can. We can do better. So I've done a lot of, this patient didn't need a stent or a bypass. So we're talking about asymptomatic patients here and symptomatic patients. But let's just look at the symptom. What can we do to change this fate? Fate is fatal. So getting back to our artery here, it has these things called, so there's a lot that's inside of this plaque, which we're not going to talk about beyond the scope, which can be addressed, but we do see inflammation and plaque destabilization, rupture and thrombus formation, blood clot formation, necrotic core, and uh, let's talk a little bit about that now that you have a diagram and it's just more than a cross-sectional photo, actual photo. Um, so what's inside of the components of a necrotic plaque? We're not talking about a soft plaque, but these things are also in soft plaques. So you'll note we'll have a lot of tools. There's a lipid-rich necrotic core, which is about 40% of the volume of the plaque. So these are target this thin fibrous cap over the art that goes faces the lumen, prone to break down and cause a catastrophe. This is something we need to address, particularly in an emergency necrotic plaque, vulnerable plaque. There's inflammatory cells. So the and then there's hemorrhage inside the plaque and outside into the lumen. So we want to think about all of these things. So, so here again, we have a picture of the moon, and then we get enamored by the moon. However, there's dangers here. There's a jaguar, there's a serpent, a snake, there's an eagle and a condor and a hummingbird. So are these, we want to turn these into allies, not dangers. So let's shine this moon onto these tools that we have and shine, move the lamppost to where the keys are, getting back to our king that left the palace. So the presence of necrotic plaque, what are the biomarkers? And what are the biomarkers of soft plaque? So this is the next part. So this is the vulnerable plaque. It's a toxic soup of, and I gave some arbitrary numbers based upon one analysis. 40% of the risk is inflammation and immune dysfunction. It's of the highest importance. The next importance is, let's say, 35%, which is plaque destabilization and necrosis, high importance. So these are mechanistically linked, so it's not necessarily separate. But if you look at total risk, it's 75% or opportunity to change metrics. And then we look at lipid and cholesterol, and in this model, it's only 15% importance versus 75%. Why just focus there and forget about everything else? And then there's other factors that we can talk about in future lectures. So please let you know that this is a very limited lecture. It's just a lamppost lecture. So there's other things we look at. We look at the microbiome, kidney disease, homocysteine needs to be measured in everybody, in my opinion, TMAO, a gut related, the oral, the mouth, what's going on there, toxic load, endothelial dysfunction, that's the inside of blood vessels. There's an extensive list in gut health and something called oxidative stress. For example, imagine that most of the damage done to arteries is after a meal. Consider that. So more to come. So looking over here, what are the markers of a vulnerable plaque? These are the 911 mark things. So I did different analysis, and one analysis, the most important one, be a troponin, which means that your heart tissue is necrotic. That's elevated. That shows destabilization of the plaque in is if it's really high, they need to get a cath or be in the hospital and they're having a heart attack. The next of importance is high sensitive CRP, which is a global marker of immune and inflammation. That's the next important test that is measured everywhere, inexpensive test. The next one is a lipoprotein A that almost nobody measures, and it does all kinds of bad things. Lipoprotein A in one model is 6 times worse than cholesterol in terms of causing harm. So we need to know that. They run in families. It's highly genetic. In fact, a lot of cardiologists don't even check it or will only check it once because they think it's that stable and there's nothing to do about it. However, there's at least 4 drugs in the drug pipeline, and we know they're very effective at lowering lipoprotein A. We just don't know yet if they help people and not harm them. So I would expect there's very favorable results and they'll be on the market really soon. There's another thing called LP plaque 2, which is an inflammatory marker inside of blood vessels. There's something called ApoB, which is more predictive by far than a LDL-C, LDL calculated. And even small dense LDL has even more predictive value than an ApoB. Some people, however, believe the ApoB is more useful and it's a very cheap test. And then there's oxidized LDL, which means damaged cholesterol. That's a sign of inflammation and oxidative stress. There's also something called myeloperoxidase, MPO, which shows plaque destabilization. You do not want to see this elevated. This is red 911. You want to see fibrinogen levels, which are blood clotting. It's some factor of inflammation, other things. And this other factor called MMP9 that I didn't put into this analysis, which you don't want to see that elevated. It's a bad marker. And there's other markers. These are all available through testing everywhere. So they're useful. So one test doesn't necessarily say it all because they measure different things. So we like to get an inventory to see where to work. and measure them all so we know how to work. And then, oh, did I do something wrong? I may have done something wrong. Let's see if I can go back. And then there's markers of soft plaque, and I made this a more general thing, high blood pressure, high ranking, lipid problems, diabetes. You want to make sure you deal with those, and smoking, kidney disease. So these are all very important things for soft plaque that we want to address. And these are high importance. ApoB, which is B stands, I guess, for bad cholesterol. We'll talk about that later. CRP again, IL-6 and IL-1 B1, beta 1, which are interleukins, they're inflammatory markers. Lipoprotein A, LP plaque 2 again, oxidized LDL, PAPA, and MMP9 that we mentioned before. So these are all markers of soft plaque that we can address. The reason to address them is that we'll know how to work in a specific patient in a personalized way if that's needed. So let's see, markers of heart plaque are the CT calcium score, and then lower levels of all these markers that we talked about, and other markers that we didn't talk about. And so just to remind you, statins promote soft plaque into being hard plaque. PCSK9 inhibitors decrease and your lipoprotein A and your cholesterol and don't have this effect. And the hard plaque is looked favorable upon the cardiology community because it turns what's unstable into stabilized calcium, calcified plaque. And so just going back to why cholesterol appeared in the world in our evolution, which we would be foolish to ignore. We want to have pliable, functional, complicated, I mean, plaques with complex function, cells with complex functions function normally. So this is a place you can stop if and rest, or you can come back and we can answer some of those questions. Hang on there. We're almost to the end of the talk. So why is ApoB superior to LDL-C, which is measured by everybody? Nobody measures ApoB. It's although it's a cheap test available everywhere. No, I was a little exuberant in how I said that. And we talked about how small dense LDL may even be better, which is more advanced test. Advanced doesn't mean superior, but it is superior. So the reason ApoB is better because it measures all the particles. It's not just the LDL, it measures VLDL, IDL, LDL, and lipoprotein A. And so it looks at the whole atherosclerotic burden. And so some people believe if your cholesterol, if you don't have cholesterol, you can't form plaque, soft plaque. So I'm not saying that it's not important. I'm just saying that put it in its look, put the lamppost where it needs to be. And so it's also more accurate than LDL because LDL-C measures mass and the ApoB measures particle numbers, and measuring the particle numbers, how much there is compared to how much it weighs, is a better metric. And the same thing goes for lipoprotein A. It's better to look at particle numbers rather than looking at mass when you get that measured. And if your lipoprotein A is elevated, then check all your blood relatives and keep your aware that there's going to be some drugs that may be really important because there's not a lot that can be done. Interestingly, female hormones lower lipoprotein A as well as a bunch of other things may or may not. So, food for thought. And so the next question is these small particles are the ones that get into the vessel walls, small cholesterol particles. So if they're bigger, they don't go in and they're considered protective, not disease plaque forming. So the small dense LDL and the ApoB measure metabolic disorders. How do you make these small dense LDL particles bigger? Well, you treat metabolic disorder. That's how you make it bigger. Right now, the cardiologists just, lipid doctors say, well, just put them on a statin to decrease their number. At least there's less of these bad guys around. However, if you want to make them large and fluffy and non-pathologic, like the small particles, you treat their metabolic disorders, which can include hemoglobin A1C. You want that in range. And your small dense LDL, again, improves with metabolic health and statin drugs, as well as other things, just for your information. And then suppose you had an elevated ApoB, that your goal would be 55 or less in a patient like this, in your, according to the cardiology community, your LDLC would be 30 or less. So what happens if the LDLC is at goal, but your ApoB is still elevated? That means you have to double down on your metabolic dysfunction. So these labs can be looked at critically and you can get more information than just a simple one lab. So there's something in cardiology and in our modern society I need to talk. So I'm going to use the A word a lot, absurd. And I'm going to talk about how absurd a residual risk policy is and that it's failed policy. So in cardiology, we look at MACE, major adverse, I'm left the A out, cardiovascular events, which ignores, so they measure that, ignores cerebral vascular events. So if you measured 10, 8 would be for the heart catastrophe, and 2 would be for cerebrovascular. So it's still important, and the arteries are arteries. So just remember that pathophysiologically, they're linked. So in the cardiology world, your goal is LDL-C to 30. Get the patient to 30. If they're on some 20 of Crestor, rosuvastatin, increase it to 40 or 80, add Zetia, and then maybe you may need another drug. And then if you get this patient to goal, then they say, thank God we've done that. And then they say the residual risk to the patient, and this is known for decades, it's not new, I'm not making it up. The residual risk is 75 to 80%, and that the statins took care of 20, 25% of the risk. Um, so I would say this is absurd. Let's treat the cholesterol particles and all atherosclerotic particles, atherogenic plaque forming particles, but shine the lamppost where the problem is, where the keys are, and that is the residual risk, which is more important. So this residual risk concept is statin centric. Lipitor was the first $1 billion drug, I believe. It's big pharma centric. After all, they have the money to do all the studies and influence, and um, and um, it's community standard. If you look and you go into the hospitals and the big insurance companies and academic institutions, which I illustrated, they're all about the LDLC and statin drugs. By the way, that clinic doctor that went to see that patient is one of the lipid authorities at Stanford. So imagine that all our guidelines, expert opinion, people sitting around the dinner tables, all the metrics that people, the big data, the what AI is looking at are these LDL-C and statins, and it's influenced policy, and there's massive inertia to change any of this. And it's just not scientifically based upon what has been known for many decades. And there's little, it's medical fact. So it's getting near the end. So there's some key points. Inflammation is primary, it's not a residual risk. Metabolic dysfunction drives progression of cholesterol plaquing, plaquing more than cholesterol. So metabolic dysfunction is more important than cholesterol. Inflammation, number one. Number two, metabolic dysfunction, which I haven't really gone into. That's a dive we're not going to go to. Then there's endothelial repair, which is the lining inside the blood vessels, is important for these soft plaques to get smaller. Regress means to make smaller. Lifestyle interventions are therapeutic, not just preventative. It's therapy, big concept. Personalized medicine based upon individual pathophysiology biomarkers, which include sleep, movement, stress, smoking, high blood pressure, toxic load, and the beat goes on, is crucial. And I would say that the medical community is not focused on this as highlighted. So here's just some repetitive notes talking about addressing these various markers. These are um, metabolic and inflammatory markers, matrix degradation and plaque stabilization. Persistent inflammation and metabolic dysfunction are central drivers of both plaque progression and event risk, like our patient going for bypass surgery, regardless of the LDL-C goal. Medical fact, not opinion. Plaque rupture, 911 emergency. So a little bit more. So now you know this information and we know the inertia in our culture, especially when big money is involved. This is just a point to just tell you that if it's up here, it doesn't do the world any good. It needs to be out in the world. And the truth is that we're creating reality at every moment. There's an old term called abracadabra, and it's said differently in different languages. I create as I speak. So I'm speaking to you right now. We are creating a future. So the world is changing as we do this. So speaking is also an action, and we want to turn this into action. Action by changing culture. And you can, like our patient, demand something. And fortunately, there's a growing field of physicians that know how to treat inflammation and metabolic derangements, expertise, and we're a growing army. There's lots to find. So we'll find opportunity where the lamppost is upstream. We have to deal downstream. Someone's having a heart attack, which a lot of times that's where the only light is. Then we can't forget all of these allies we have there that are going to help us in the darkness, and we want to move this to everywhere, and we need to look both upstream and downstream, and you will find opportunity. So going further in this case is beyond the scope. So just to finish the case, his omegas, his fish oil type things were off. This is omega-3 index was 5.6. We want it to be over 9. There's a lot of arachidonic. So EPA is anti-inflammatory and arachidonic acid is omega-6 is pro-inflammatory. The ratio is unfavorable. So there's a lot of inflammation going on. And this can be treated with omegas. The LP little a, they told us it can't be, it's static. They won't recheck it. However, a lot of doctors, however, it went from 121 to 178. What the heck happened there? So it isn't static. And the lipoprotein A and the hemoglobin A1C went from a year before from barely pre-diabetic to full-on diabetic. How did that happen? That needs to be addressed. One of the metabolic disorders. This is a metabolic and inflammatory issue. And the MMP9, the metalloprotease, was above normal. So this shows potential necrotic plaque, and this number needs to be mitigated to as close to zero as we can get it. Thank you for your attention.